Sarah, I will pass it on to you.
Thank you. Good afternoon, everybody. Well, good morning still, briefly. My name is Sarah Dugan. I'm a mental health pharmacist. I'm faculty here at Neomed in the Department of Pharmacy Practice and the Department of Psychiatry. So our topic today, there we go, to kick off the Psychopharmacology month is Psychopharmacology and Polypharmacy. So we have didactic blitzes. So full disclosure, this is going to be a really high level overview. I could have used all 4 of the monthly presentations on this topic alone and probably still not done it complete justice. So we'll see what we can do with this. 3 objectives I want to accomplish. I want to identify the classes of psychopharmacologic medication. So generally, what are the classes that we're thinking of when we talk about psychopharmacology? What are some of the common uses that we can see for these classes? As we get into it, you'll see it's not a one-to-one. We can actually mix and match quite a bit. And then I want to describe some scenarios where combinations of medications or that polypharmacy might be used. In some cases on the positive side, and in some cases where we might want to be recommending some changes. But before we get started, I want to make sure everybody's on the same page. So definitions. I actually went to dictionary.com to get these, to try to get the most general, broadest definitions I could find. So I broke down each of the words. So psycho, from psychopharmacology, indicating the mind, psychological or mental processes, representing the psyche and the psychological. And then pharmacology being the study of drugs, including preparations, uses, and effects for the treatment of disease. So when we combine them, we're really focused on the use of medications for the treatment of mental health type conditions. So that's the types of medications that we're going to be focused on this whole month of September. And on the flip side, polypharmacy. And in some circles, polypharmacy may sound like a 4-letter word. So sometimes it's really looked upon as being negative, and I want to draw the distinction, especially for some of the individuals that you're caring for. Sometimes there are reasons to be using polypharmacy, but we got to make sure we're making the right decisions. So poly being much or many, pharmacy, the art and science of preparing and dispensing medications. So in this case, really focusing on the use of at least 2, if not more medications to treat a single condition or disease or a compilation of symptoms. And I make that distinction because sometimes the lines get a little bit blurry. So let's focus on the psychopharmacology first. In terms of full disclosure, the medications that I'm going to talk about, not all of them carry official FDA approved indications for these diagnoses. So sometimes we use the medications for indications that they're not formally approved for. Doesn't mean that they don't work, but I just want to make that distinction. You got to do that with the CE presentation, so just in case. So with the pharmacology, these are generally the boxes of medication classes that we're using. Antidepressants and antipsychotics, things like anxiolytics, our benzodiazepines, mood stabilizers, which I like that it's right underneath the antipsychotics because sometimes, quite often actually, antipsychotics can be used as a mood stabilizer, so those 2 blend together. We have some medications that we use for substance use disorder. It's going to be, I wanted to include it for completeness sake, but this is kind of a unique class. And then I left a box for miscellaneous. So as you may have seen in the treatment of a number of the individuals that you care for, sometimes there are medications that are not necessarily mental health type medications that we can use sometimes for the treatment of symptoms related to their mental health diagnosis. So sometimes we really have that other category. So I left that there just as a placeholder to keep in mind that things don't fall into neat boxes all of the time. So what I started to do here was just to break down each of the classes, to look at what do these medications generally do and why would we be using them, to put the pieces together. What I realized was I did not have enough space on any of the slides for this. So by the end of September, you'll have a separate document that has a table that actually breaks apart all of the medications, brand name and generic name, their approved uses, as well as their non-FDA approved uses. So other reasons that we could use them. I don't have that quite done yet because it's relatively extensive, but I will have that for you by the end of the month. So don't be panicked that you don't see all of the medications listed here. I just didn't have enough room. So I'm going only in alphabetical order, just not to give preference to any of the medication classes. So for our antidepressants, there are quite a few different subcategories in antidepressants. Each of them tend to work mainly on 3 different neurotransmitters: dopamine, norepinephrine, and serotonin. They are quite involved with attention and concentration, memory, motivation. They're involved with mood, with wakefulness, with appetite, with interest and pleasure in activities. So the medications usually are going to increase the concentrations of these 3 neurotransmitters in the hope that it will help address some of those depressive symptoms. In addition to the treatment of depression, other places antidepressants can be used. They're first line for a number of different anxiety disorders. We can see them used for some autism spectrum disorders, especially disruptive, repetitive behaviors. Sometimes they can be helpful for those. We can use them sometimes in eating disorders as well as in self-injurious behaviors. So I included 3 different types of medication antidepressants. So fluoxetine is one of our serotonin reuptake inhibitors. Venlafaxine is one of our serotonin norepinephrine reuptake inhibitors. So that works on 2 of those neurotransmitters. And bupropion tends to work on mainly dopamine, but also the norepinephrine. So 3 different examples that all technically are antidepressants, but they do work a little bit differently. So sometimes it takes some mix and matching within the class to find the best fit for our patients. Our antipsychotics, I think this class has definitely diversified incredibly. It has a number of actions. Its primary actions tend to be on those neurotransmitters, so dopamine and serotonin. Each of them do a number of different things, so I feel like that's almost disingenuous, but those really are the main actions. They do a bunch of other things as well. Uses. So most of them had an initial approval for schizophrenia or for psychotic type disorders. Oftentimes they also would get an early approval for aggression and agitation that would go along with those mental health diagnoses. This is really diversified for treatment of bipolar disorder, so helping regulate mood. So that's why I said it can kind of blend into the mood stabilizer piece. It can be helpful for some of the behaviors associated with autism spectrum disorder. In patients that haven't responded well, that have anxiety or depression, we could use this as adjunctive treatment. And it also sometimes can be helpful in patients with self-injurious behaviors. There is a wide variety of tolerability in response to the antipsychotic medications. So we tend to have 2 classes. The older class, I use the haloperidol or Haldol as that example. They still work very well, but we do need to worry about some side effects, the movement disorders being one of the most common. Then for our newer agents, things like the Risperdal, the Abilify, the Seroquel, these are a little bit newer. They work more on serotonin than the older agents do, but they come with their own adverse effects. So still the movement disorders, but we also see some metabolic things as well. Weight gain, increases in glucose or cholesterol levels. So they can be very effective, but we got to balance out those side effects that can happen. Our anxiolytics, so these would be medications that are a little bit more focused just on anxiety. And I wanted to put these here because I think we sometimes forget about them, especially because the antidepressants can be first-line treatment for anxiety. So these medications start working on different neurotransmitters. So still that serotonin, but we can see other neurotransmitters like acetylcholine show up. And they can be useful sometimes for agitation, like the hydroxyzine or the Vistaril, but they also can be used for anxiety as well. So lots of variety. We've got lots of options to choose from. Our next set of medication classes, so are benzodiazepines. So these are agents that work on the neurotransmitter that's the main inhibitory neurotransmitter in the brain, one of the chemicals that helps kind of calm things down with the neurons. For that reason, we see the benzos used for sleep disorders, for insomnia, for seizures. We can also see it used for anxiety or agitation. So some of these examples would be Xanax, Ativan, Valium, the Klonopin. So this class of medication, we kind of have a love-hate relationship with. They're very effective at treating anxiety, but they can be misused and abused. So there was kind of a shift from, hey, these work really well, to there are people who are misusing them. We need to restrict their access. And I think now we're trying to get a better relationship with them, where they're effective, and there are some people that just need standing doses of the benzodiazepines. But we need to make sure that all of the other pieces are in place, and that the most logical treatment for the patients is continuing to be on a benzo, because in some cases patients can develop a tolerance, so the medication that they take doesn't work quite as well as it used to. So a delicate balance that we want to keep in mind. Our mood stabilizers, this is a variable class. It includes medications like lithium, but it also includes a lot of medicines that also are seizure medicines. Your Depakote, your Lamictal, sometimes Topamax can be in here as well. So these medicines can be used for quite a few different indications. So in this case, the Depakote has formal approvals for seizure disorder and headache prevention, as well as bipolar disorder. So we can really see a lot of variability there. The medications work on a bunch of different neurotransmitters in the brain. They have different actions, and some of them just work on the channels that control how often some of the neurons fire. So we have quite a bit of variability, and if one medication doesn't work, we're not going to a close cousin. We could go to something that works totally different within this class. So with that in mind, there might be quite a few different options, and this might be one of the areas where we see combination therapy, and it makes sense because we're doing lots of different things. The sedative hypnotic, so things for sleep, the benzos can be used for sleep. Some of our antidepressants can be used for sleep, like trazodone, but ones that are sleep specific work on our main inhibitory neurotransmitter and our melatonin system. So you can see things like Ramelteon, which is a melatonin prescription medicine, or what they call our Z drugs, things like Ambien, that are specific for just helping with insomnia. Last chart, are stimulant medications. So I would say you see these pretty frequently. They work on neurotransmitters, so dopamine and norepinephrine, those pop up again, and they really help increase the amount, and in some cases actually activate the receptors for dopamine and norepinephrine. The goal is helping patients focus and filter some of the outside. There's all kinds of input that's coming at you right now, but hopefully you're able to filter some of that out and focus just on what it is that I'm saying and what's on the slides here in front of you. So the medications can really help with those. And our two main classes there are the methylphenidate class, like the Ritalin class, and our amphetamine salt class, or our Adderall type class. These also carry the risk of potentially being misused. So diversion is something that is thought of as people are prescribing those. It's also one of the reasons why adults with ADHD, we don't use these first line. And then for our substance use disorder, this was for completeness sake because I felt guilty leaving it off. But we do have a number of medications that work in different areas that can help target some of the symptoms related to substance use disorder. Sometimes it blocks the effect of the medication, like what the naltrexone does. In other cases, it can work on other neurotransmitters to help with the cravings or some of those other impulsive decisions that go along with substance use disorder. So what do I want you to think about with all of that information there? So lots of different classes, lots of different options. We need to know, what are we using this for? So as you could see, each of those classes could be used for a whole bunch of different reasons. We need to know why. What's the why? Why are we using this? How are we going to know if this is actually working? That's also very important. Sometimes it seems like that should be super obvious, but if a patient's anxiety is so out of control and they are acting out, then we would expect, hey, their acting out is going to get better. But if it's more of a depression, then maybe we're looking at improving the amount of time that they're sleeping. Maybe it's improving their appetite. Maybe it's a little more engagement with their family. So we need to be very clear on how we're going to know whether or not it's working. Because as case managers and those that are helping educate the family, that's such a valuable resource to provide that information back to the prescribers. But we got to make sure we're all on the same page. And also being on the same page, we need to know when we can expect the change. So for agents like benzodiazepines, you can see improvement in anxiety right away. Within half an hour to an hour, likely those anxiety symptoms are going to be a little bit better than they were. For agents like our antidepressants, like the Prozac or the Zoloft, it's going to take time. It may take a month or two before we start to see improvement. And if patients are thinking it's going to work with the first or second dose, they may bail on those medications right away. So we need to make sure that we're on the same page. How do we know it's going to work? And when should we expect to see a difference if the medication is going to make a difference? And one of the reasons that's so important is, yes, we can use them to treat the symptoms, but they all come with adverse effects. So there is baggage that happens with every single one of those medications. So we need to make sure that we're appropriately balancing the efficacy with the side effects. For, again, full disclosure, most of the combinations have not been well studied. ADHD is one of the few examples where the combinations have been better studied. So with polypharmacy, there may be situations where we're using 2 or more medications, and they may be from the same class or from a different class. So even within polypharmacy, it might be a little bit different. One example might be a patient who has obsessive compulsive disorder. So their anxiety, maybe they were on the Prozac, the fluoxetine, it wasn't well controlled. We're going to switch them. We're going to switch them to the Effexor, the venlafaxine. But as we start to switch them and we cross titrate, maybe the patient's doing really well, so we just pause right there. So they have obsessive compulsive disorder, and we're using 2 different antidepressants to help treat that temporarily. So that would be medicines in the same class, but there might be a reason why we're doing that. Alternatively, we might use medicines from different classes. So if a patient has pretty significant aggression and agitation, very violent outbursts that are really impulsive, then maybe in some cases we might be using a stimulant medication and an antipsychotic medication. So the aripiprazole, the Abilify, and a Ritalin, the methylphenidate, to kind of help with some of that impulsivity as well as that agitation and aggression. So in that case, we're using different classes. Both of those qualify as polypharmacy. But I do think it's important, if we're using lots of medicines, especially in children and adolescents, that we hit the brakes. Why are we using these? Is it part of a titration? Are we essentially going to get rid of one and switch over to a different one? Are the child's symptoms getting better? Are we sure that this is working? Because that's something that's really important, especially if symptoms are pretty severe. We tend to add, and it's important to ask the question, well, is this actually working? If the child continues to have symptoms and they've been on this medicine for a long time, maybe that medicine's not the best fit for that child, and we need to look at maybe getting rid of it and using something different. And then what are the side effects? Some are really obvious. If they have movement disorders and their head's all twisted, that would be pretty obvious and we know that right away. But if there's other things that are happening, it causes restlessness, or it's starting to cause some weight gain or other metabolic changes with their sugar or their cholesterol, we got to make sure we're following those as well. So if we see multiple meds, we got to collect some information. Because more is not always better. We need to make sure that we're monitoring. And again, is it effective? Do we know that it's working? If it is, then that might be justification for some of the side effects. But if there's pretty significant side effects, then maybe that trumps having any improvement in the symptoms that the patient has. And in some cases, patients might have medications that are working in opposite directions. So we need to make sure we're not making things worse. In a child that has ADHD, maybe they're on an Adderall prescription, but they also have insomnia. So we're trying to give them melatonin and other medicine to get them to go to sleep. Well, maybe that Adderall dose is too high. And if we drop that, maybe we don't need to use as much of the sleep medicines. So we need to keep those in mind as well. So the big take-home point is it is all about balance. Sometimes it's appropriate to use multiple medications, but we need to make sure that those benefits are offsetting any of the costs, those adverse effects that might happen with the child. If they have other comorbid conditions, maybe we can use one medicine that'll help with a whole bunch of things. They're having a lot of mood lability and they have chronic migraines, then maybe Depakote's a great option for that patient. So then they're not on multiple medicines. And this is also why it's really important that we get those medication histories so that we know what worked, what didn't. Did we use enough for long enough? If we say, hey, you know what, that Paxil never worked. They took 5 milligrams for 2 days. It made them nauseous. Okay, well, that's a common side effect right away, but we shouldn't eliminate that as a complete option because they weren't on a high enough dose for a long enough period of time to be able to make that determination. So that really helps inform what the next steps would be for treatment. So just to tie things up, lots of classes of medicines that we're going to go through in different chunks throughout this month, but it really is important that we're all on the same page, knowing why we're using what we're using, and being able to figure out if the efficacy is able to offset those side effects. With that, I will stop share and turn it back over.